Assalamualaikum warahmatullahi taala wabarakatuh, and a very good morning to all our audience. I am Marhani Midin, the chairperson for this morning CPC, and today's CPC is specially brought to you by the Department of Psychiatry. It's going to be on an interesting case. It is on a mom who was keeping it mum. Yeah, and there'll be a special highlight on understanding the psychodynamic of this case who had a chronic jaw spasm. So before we begin, I would like to introduce to you our speakers. Yeah? Our first speaker is Dr. Cho Vien. Dr. Cho is our trainee in the Doctor of Psychiatry program, and she'll be presenting on the case. And our second speaker is is specially brought to you from the Department of Medicine. He is Associate Professor Shahrul Azman bin Muhammad Rani. He's a consultant neurologist. Yeah? Thank you, Prof. Azman, for supporting us.
Pleasure.
Okay, all right. So our third speaker is Prof. Dr. Ruzyanei bin Jaafar. She is a consultant psychiatrist from Department of Psychiatry. So, all right, okay, I think we can begin our presentation. So I'll pass over the mic to the first speaker.
Thank you, Prof. So, good morning, everyone. My name is Vien, medical officer from Psychiatry Department, HCPM. So today I'm going to present on this topic, mom keeping mom understanding the psychodynamic of the case, presenting with chronic jaw spasm. So Mrs. R is a 51-year-old Muslim Japanese housewife with 3 children. She was referred by neuromedical team for psychiatric assessment as she experienced abnormal movement of the jaw that restricted her speech for the past 2 years. So she was well until 2019 when she started to have this difficulty in controlling her jaw movement associated with numbness along the jaw region. First onset while she was praying and the speech was restricted as she felt there was a tightness at both of the temporal mandibular joints. So she has to use extra effort to force her mouth closed, accompanied by pain as well. So she actually aware of what she wanted to say, but unable to pronounce the word properly due to the jaw tightness. It would occur suddenly and she was unable to control it. And the symptoms was much more obvious and pronounced when she was at home, but less noticeably when she was outside. No difficult in eating or swallowing, no drink or saliva, and there is no spasm around the jaw area or muscles, and no recent trauma or fall, and no other neurological symptoms or body weakness as well. And the pain is not associated with chest pain, shortness of breath, abdominal pain, and there is no sensation of unreality, detachment, or being an observer of her own thoughts or surrounding. Other than that, she also had this persistent low mood since 2019, associated with losing interest, and also she was unable to sleep well, and she felt hopeless, helpless. However, the appetite was normal. There were no suicidal thoughts or homicidal thoughts. Other than that, she has these anxiety symptoms as she persistently worried of both of her children's health condition. She also found it very difficult to control her worries as well, and the energy level was low and easily tired after she performed house chores and difficulty in concentrating when performing prayers. There were also muscle tension around the neck and also the back area. Occasionally, she experienced these panic attacks where associated with palpitation, shortness of breath, dizziness, nausea, and feeling losing control. but the panic attack will resolve on its own, and she denied of her sister worry of another panic attack. And there is no maladaptive change of behavior related to the attack. And she denied fear in crowded or enclosed space, and there is or any fear in the social situation. There is no manic or hypomanic or psychotic symptoms. So the stressor that can be identified at the time is her son started to exhibit abnormal behavior, where there's social withdrawal, neglected self-care, and later he was treated as schizophrenia in hospital Putrajaya, and the symptoms were not well controlled. The son would occasionally become aggressive, and therefore she has to be vigilant all the time. She even asked the son to sleep with her so that she could monitor him closely, and frequently woke up at night to check on her son's condition. On the other hand, the eldest daughter also diagnosed with this disseminated TB in 2018. So this was quite stressful for her, and as she was afraid of losing her daughter. So the son's abnormal behavior also causes her to be on guard all the time, and she could not sleep on most nights. There was also significant distress in the impairment in the social function, where she communicated less with others. And she also had difficulty in completing her daily house chores due to all these symptoms. But despite having these symptoms, she did not acknowledge herself as acquiring any serious illnesses, and she did not being excessively worried about her health. So during this first onset of these symptoms, the doctor actually brought her to Hospital Putrajaya to seek treatment. So initially, she was referred to ENT team and treated as temporomandibular jaw spasm. And nasal endoscopy finding was normal, and there's incidental finding of this acute sinusitis. Later, OMF team also extracted both of the wisdom teeth, as probably might cause the locked jaw, but the symptom persisted. She was then referred to psychiatry clinic in Hospital Putrajaya, but she was discharged after first clinic appointment as there was no any psychopathology elicited at that time. So later, her doctor actually brought her to see a neurologist in private hospital, and MRI, EEG, blood investigation were done. All shows normal result. She was started on this trial of PEP clonazepam, but showed no improvement at all. She even went for physiotherapy and traditional massage. But the symptoms persisted. She was then referred to neurologist in HCPM in 2021, and seen by the neuromedical team and being treated as a typical jaw spasm with the possibility of stress-induced or temporomandibular jaw-related tendinitis or arthritis. So initially was tried on this tabaclofen by LGBT, but the spasm worsened. So in view there's a possible of this stress-induced component, so she was referred to our psychiatric team in HCTM. So looking back at the past psychiatric history, her first psychiatric contact was at 18 years old in 1988, where she presented with inability to focus or concentrate during prayers, where she found it difficult to recite certain words. So she was afraid that God had not accepted her prayers. So the sister brought her to seek treatment, but there were no jaw stiffness or spasm. Speech was normal at that time. Eventually, the patients defaulted follow-up because her problem resolved spontaneously within the same year and not started on any medication. So that time, the stressor that can be identified was she was undecided to further her study in STPM. So later, at 34 years old, she experienced another recurrent, another symptoms where she had this recurrent chest pain, and the pain was pricking in nature. She sought multiple treatments, did OGPS, but the result again came back to be normal. She was started on gastric medication, but the symptom did not resolve. So that time, she was a bit worried on her younger son, who was having this persistent abdominal pain and was suspected to have malignancy. But eventually, the son cleared of malignancy and the chest pain was then resolved. whereby when she was 44 years old, she experienced a new symptoms, which is upper limb pain, cramping in nature radiating to the back, worsened at rest, but relief when doing activity or tasks. And X-ray bloods were normal as well. And that time she was worried about her husband, had difficulty in obtaining permanent residency in Malaysia, and husband had to return to Indonesia to settle those things. But after he managed to obtain permanent residency a year later, the arm pain gradually subsided. So this is the family tree of Mrs. R, and she has 3 children, and 2 of her daughters are actually highly educated as well. And the youngest son is 22 years old, diagnosed with schizophrenia. But no other family members has psychiatric illness or anxiety problems. So let's move to the parents. The father of Mrs. R. He is a farmer and a breadwinner for a family, and he is a religious person as well. And then he always instill the religions in her children. He was also a hot-tempered person and would express anger by shouting or throwing meals at his wife and children, but never hit them. He did not involve in children's education and academic performance, but he will still provide the basic need in the house. And Mrs. R is not very close to the father, and eventually her father passed away when she was 16 years old due to a motor vehicle accident. So Mrs. R's mother was a housewife and practiced her authoritative parenting style. So at the age of 51 years old, mother complained of numbness on one side of her cheek and mouth, but she can talk as usual, no difficulty in swallowing or eating. And later her mother was admitted to hospital and had an operation around the nose area. So during which Mrs. R had to take care of her. So they were actually unsure of the diagnosis, but after the surgery, mother became bedridden and ADL dependent. So later the mother's condition deteriorated and she passed away a year later. So Mrs. R was born in Hospital Banting, Selangor, and delivered via SPT, term and no complication during the delivery. No significant health problem in childhood, and the developmental milestone was up to age. So there are several childhood adversity that can be identified. Her father is overly religious and hot-tempered with history of domestic violence. And she lives in poverty, where her siblings and Mrs. R needed to work at a coffee shop for their pocket money and also schooling. So the academic performance was quite well, and she achieved a grade A in SRP and also good grades in SPM with pangkat 1. And later she was given this opportunity to pursue her study in STPM Form 6. So, but she declined the offer as she worried about the STPM syllabus and she would anticipate failing her exams. Yeah, there was also excessive worry about the orientation period as well. So later she was offered as a job as a substitute teacher, but she refused it because she has no confidence. And then eventually she worked in an electronic factory as an operator. And however, she quit the job because the schedule was too packed and it affected her to perform prayers on time. In the end, she became the private teacher and taught about religion subjects. But after her first pregnancy, she decided to become a full-time housewife in 1993. So there were actually no relationship issue with her husband. Husband is very supportive and no known history of substance abuse. So pre-morbidly, Mrs. R is a shy, quiet person and highly religious person. She likes to attend religion classes and comfortable only with small circle of friends. So we can see there's anxious traits in her, where she kind of easily worried type of person. So for example, she always asks her children to call her whenever they are away, and she would worry and had difficulty in sleeping if her children were ill. So there's also some obsessional traits observed in her, where she needs to be punctual and as she ensured herself to be present at school on time. And then she was very hardworking and she completed any homework or task given by the teacher when she was in primary and secondary education. So during stressful situations, she normally uses these religions as coping. So for example, during bad weather, she will ask her husband to perform prayers because she's worried that like any disaster like fallen trees or floods that could destroy her house. So these were actually the blood investigation done in HCTM in 2021. All the bloods are normal. So including MRI brain, just findings of acute sinusitis, EEG were normal, and then PHQ-9 shows that there's minimal depression, and GAD-7 shows that there's a moderately severe anxiety. So the provisional diagnosis, first one would be this functional neurological disorder. The points that supporting this diagnosis symptoms of altered voluntary motor, which is the abnormal jaw movement, and there were some positive clinical findings, but incompatible with organic disease and quite inconsistent across the different parts of examination. So later I will show some videos. So the symptoms deficit is not better explained by medical or mental disorder, and it causes significant distress and impairment in social. So the second provisional would be this generalized anxiety disorder. So as she has excessive anxiety and worry about her family, and then occurring more than 6 months, that she found it very difficult to control the worry. And there are others associated symptoms like being easily fatigued and also difficult to concentrate and muscle tension at the back and the neck area, and also she has these sleep disturbances. So another provisional diagnosis would be persistent depressive disorder, where she had this depressed mood for most of the day and lasted for at least 2 years. And the depressive symptoms included insomnia, low energy, low self-esteem, poor concentration, and feeling hopeless. So she never been without these symptoms for more than 2 months at a time. The differential would be this somatic symptom disorder. So the points supporting it is these symptoms result in significant disruptions of daily life, and the symptoms is involuntary and is actually real for her. But the points against is the somatic symptoms are physical symptoms and maybe can be explained by like gastric pain, can be due to gastritis, and do not typically have loss of function. The excessive thought, feeling, and behavior characterizing somatic symptom disorder are also absent. So she actually under our psychiatric follow-up since 2021. There are actually multiple anxiolytics were tried on her, but the symptoms were not really fully relieved and not well controlled. So the medication include escitalopram, Seroquel, and then egomelandine, and mirtazapine, duloxetine. So in the end, she actually started to refusing to take any medication. So in the end, a shared decision has been made with Mrs. R to not take any medication. So psychoeducation has been given to her to make sure that she understands her illness well. And deep breathing, relaxation technique were taught to her. But she is not really suitable for this CBT as she has difficulty in producing speech and is not psychological minded. So we are more concentrate on this behavioral stress management. Like for example, we are focusing on the activity that she likes, include gardening, to actually like distract her and manage her stress. So we even liaise with this Hospital Putrajaya in terms of the treatment and management for her son's condition. So we last seen her in clinic around June. She was not on medication since this year January, and she also still have the same symptoms and did not talk much at home. She feel hopeless about her illness and wished to be mute rather than suffering the pain. So, however, the mood was a bit improved compared to a few months ago as the sun conditions were more manageable. So she was able to perform house chores and daily activities, including gardening. And otherwise, no sleep disturbances. She was able to tolerate already, and then no suicidal ideation that time. Okay. So in the end of the presentation, I will show you two videos. Okay. So I'm gonna play two videos. First video was actually taken at a patient's house. The second video was taken during psychiatric clinic consultation. So let's see any difference in the symptoms presentation in these two different settings.
Ini juga adakan kewajiban melakukan perkara yang diajukan, menjaga hudud Allah, menjaga kebaikan, dan tidak menjadi apa yang diidamkan oleh Allah. Karena emang bakal untuk selama mana? Kalangan banyak mengkaji dan melihat. Kalangan ini mungkin khusus pada zaman Nabi Muhammad SAW. Karena banyak kendaraan dalam.
So we can see that actually in the first video, a patient had a difficulty to articulate and pronounce the word properly. So she was a bit uncomfortable and appeared anxious and probably in pain as well. So we move on to the next video to see any difference.
Karena kalau Pak Roman tuh saya nggak buka mulut sih, itu belum ada perkataan dan saya mulut saya datang di luar, saya nggak kartu balik itu susah. Kalau susah ambil masuk kombinasi. Kalau pada aku saya sakit sama dia berlaku. Berita kalau saya berita juga. Jadi sentiasa, sentiasa. Kalau orang masih sentiasa. Macam kadang saya nak cakap tu macam break kat sini, saya tak boleh cakap langsung. Ini dan saya okey, nanti saya balik dekat kereta nanti dah tahu sampai kereta tak perlu sampai rumah pun. Yang ini kalau macam dia buka mulut tu kan, susah tu. Kalau saya tak sengaja, saya tak ingat yang saya kena sakit. Saya boleh cakap satu perkataan satu ayat boleh. Maksudnya kalau kita ingat ini kita tapi boleh cakap panjang masa saya ingat. Okey. Benda tu saya bukan sengaja. Ialah tapi kita ingat tu dia boleh cakap lebih lancar. Tapi jarang walaupun di rumah lah tapi tak sampai rumah pun tadi sebab saya dengan anak. Kalau kawan tidur, saya boleh cakap dalam saya tu bayar. Oh, masa malam bangun tu macam saya nak tidur.
So from the second video, we actually can see that she was not able to narrate her symptoms and produce her speech quite fluently compared to the first video. So actually from these two videos, there are actually symptom inconsistency in terms of the speech production and depending on the situation and also settings. So with that, I end my presentations and thank you, everyone. Let's move on to the next session. Thank you.
All right. Thank you, Vien. So, Prof. Azmin, so sorry I mentioned your name as Prof. Azman this morning.
It's all right, okay.
I certainly remember you and remember your name. So sorry about that. Okay, so yeah, I'll pass over the mic to you to discuss on
Okay.
the other part of her.
Thank you, Prof. Marhani, and thank you, Dr. Vien. I'll share my slides. Okay. Can you see my slides? Yes?
Yep. Yes.
Yeah, okay. So good morning. Thank you to the Psychiatry Department, Prof. Ruzyanei, for inviting me to give this presentation. My name is Dr. Shahrul Azmin. I'm from the Department of Medicine, Faculty of Medicine, University Kebangsaan Malaysia. And my presentation is entitled Functional Neurological Disorders. This is the content of my presentation. I'll say it now because I'll forget later on, but treatment, I won't touch too much on psychotherapy, cognitive behavioral therapy, because I think that'll be covered by Prof. Ruzyanei. So, functional neurological disorder, what is it? It sits in the interface between neurology and psychiatry. It's been neglected in medical teaching in the 19th century and the 20th century. But over the past 2-3 decades, appropriate attention and research has been afforded to it. Over the centuries, it's been given many names, sometimes pejorative. So hysteria, dissociative, conversion disorder, coined by Sigmund Freud, psychogenic, are all describing the same entity. Presently, the term functional neurological disorder is preferred. There are generally 4 subtypes, and patient can have more than one subtype at any one time and change subtype as the years progress. And I just want to state it here that functional neurological disorder is not the same thing as malingering, as malingering is a factitious disorder. So epidemiology of functional neurological disorder is seen in as young as 4 years old and as old as 94 years old. The mean age of onset differs according to the subtype. So for functional movement disorders in their 30s, functional seizures in their 20s. There is a strong female preponderance, but the gender gap is narrower in early and later life, and prevalence is 50 to 100 in 100,000. Risk factors. One of the most important risk factors is exposure to psychological stressors and history of childhood adversity, which Dr. Vien very vividly illustrated in our case. Odds ratio, it confers the odds ratio of 3 to 4 towards developing functional neurological disorder later in life. Now, surprisingly, in a meta-analysis on case control studies of functional neurological disorder, events indicating psychological stress are not recorded in 50% of patients. And this is noteworthy because the not inconsiderable amount of time and effort in trying to uncover these events during history taking. And although in the new DSM-5 criteria that we'll be touching on later, a history of psychological stress is not necessary to make a diagnosis of functional neurological disorder. In addition to psychological stresses, there are many other risk factors towards developing functional neurological disorder. It can be clinical, social, cultural. So Professor Mark Hallett from Harvard University and his group proposed a categorical system for risk factors according to whether they are predisposing factors, precipitating factors, or perpetuating factors. In predisposing factors, you have anxiety, depression, stressful life events, as mentioned in my previous slide. But not everybody who have these conditions go on to develop functional neurological disorder. This is where the concept of precipitating factor comes into play. So an illness such as vertigo would be can be a precipitating factor towards developing functional dizziness, or a seizure can be a precipitating factor towards patients developing functional seizures. In our case, the precipitating factor could be something that was experienced by not by the patient itself, but by the her close relative, which is a mother who developed some swallowing and chewing illness, which led to her death. Another category in this framework is the perpetuating factors. So diagnostic uncertainty, misdiagnosis, unnecessary investigations are sometimes issues that are within the control of the treating physician, and addressing these may potentially modify the natural history of functional neurological disorder in some patients, especially when you consider the lack of good treatment in functional neurological disorder. So, what is the pathophysiology of functional neurological disorder? We know it's not a structural brain problem, but a functional one. So brain MRI, CT brain will be normal. Over the past 2-3 decades, a lot of imaging studies using functional MRI and positron emission tomography have been performed. In summary, they show an increased activity in the limbic areas involved in self-awareness, introception. Introception means perception of the inner workings of your body, emotional processing, so limbic regions. And there is a reduced activity in the cortical regions involved in motor preparation, selection, and monitoring of movements. So, what does this mean? So, we go with first principles in that to state that the brain is not a sponge in terms of how it accesses information. It does not absorb information from the outside world unmodified, unadulterated, but it's influenced, colored by internal factors from higher centers of the brain. In other words, stimuli such as nociceptive stimuli, visual stimuli, proprioceptive stimuli is modulated by factors such as emotion, attention, expectation to form perception. So for the following slides, I'll use feedback to indicate nociceptive, visual, proprioceptive stimuli, and feed-forward signals to indicate elements relating to emotion, attention, expectation. So you may see it as feedback is the direction from the external environment to the internal environment, i.e. consciousness, and feed-forward is the direction from the higher order function of the brain, deeper recesses of the brain, i.e. subconscious, towards consciousness. To illustrate my point, this is an old article published in 1946, reporting the phenomenon of soldiers mortally wounded in the battlefield, yet report little or no pain. So the pain was not commensurate with the injury that was sustained. So what's happening is probably that the feedback in the form of nociceptive stimuli is being modulated by feed-forward signals in the form of attention away from the wound. Perhaps attention is being directed to more important issues like trying to survive the war and not to be killed, and thus giving the perception of reduced pain intensity. Another example is possibly a similar thing. Possibly this is what is also happening, where feedback, i.e. nociceptive signals from the peripheral afferent fibers on the chest wall, on the back, on the cheek, is modulated by feed-forward signals and giving rise to the perception of no pain. The same concept also applies for visual stimuli. This is a screenshot of an internet meme that became viral in 2015. Some people perceive the dress as blue and black, and some perceive it as white and gold. Again, the feedback in this case, the visual stimuli, is being modulated by feed-forward signals such as preformed beliefs, past expectation, giving the perception of two different color combinations in different people. So normally, i.e. in those that do not have functional neurological disorders, feed-forward signals and feedback signals match. And in the event of where there is discrepancy, adjustments are made in areas of the brain involved in multimodal integration. In patients with functional neurological disorder, there is an overweighting of feed-forward messages under the influence of past expectations, beliefs, attention, emotion. And what happens is the past expectation of an outcome dominates over the objective data regarding current outcome and modifying perception. So then the situation arises where the brain feels what it wants to feel and the brain sees what it wants to see. So what happens in functional movement disorder, the condition that Dr. Vien presented? So in functional movement disorder, patients report the loss of voluntary control over the body, i.e. they feel that they don't control their jaw, their mouth, their tongue, their upper limbs. This can also be explained by the framework of feed-forward and feedback signals that we use for pain perception and visual perception. So the intention of movement starts at the dorsolateral prefrontal cortex and proceeds to the supplementary motor area where movement is planned. And the command goes to the motor cortex where the movement is executed. Sorry. However, in parallel, feed-forward signals are transmitted directly from the dorsolateral prefrontal cortex, where the intention arose, from the supplementary motor area, where the movement was planned, and the motor cortex, where the movement was executed. To an area of the brain that would integrate all these feed-forward signals with subsequent feedback signals from the proprioceptive afferent fibers when the movement occurs. So you can consider the feed-forward signals as containing prediction of movement derived from past experiences or beliefs, i.e. muscle memory. So we touched in the previous slides on how functional neurological disorder, there is an overweighting of the feed-forward signals. A similar thing happens in functional movement disorders. There is a mismatch in feed-forward and feedback signals in the areas of the brain involved in multimodal integration. But unlike in previous examples, where the brain sees what the brain wants to see, or when it comes to pain, where the brain feels what it wants to feel, in functional movement disorder, this mismatch gives rise to a feeling of loss of agency. So the patient feels that the experience what if she feels an involuntary movement or an outside force controlling the movement. So we've talked about pathophysiology, where we go now with diagnosis. According to the DSM-5 criteria, the diagnosis is made if the patient has one or more symptoms of altered voluntary, motor, or sensory function, and clinical finding provides evidence of incompatibility between symptoms and recognized neurological conditions. In other words, the positive signs for functional neurological disorder. Now, this departs significantly from previous versions of DSM-4, which states that exclusion of other disease is required to make the diagnosis with the presence of psychological factors. What this means is that with the new DSM-4, DSM-5 criteria, functional neurological disorders can be diagnosed in the presence of existing organic neurological disease because it's no longer a diagnosis of exclusion. So what are the positive signs of functional neurological disorder? That depends on the subtype of the functional neurological disorder that the patient has. However, common to all the different subtypes are the variability of symptoms from consultation to consultation, from day to day, from week to week. And then there is a general quality of effortfulness, sometimes grimacing expression when following commands. I don't have time to go through all the positive signs, so I select some of the interesting ones. So with regards to positive signs in gait and weakness, patient tends to fall towards the support. So when you examine the gait, and your patient tends to falls towards the examiner or the chair or the wall. And they have this non-economic form. What does this mean? Non-economic form, usually in organic weakness from a stroke, because of loss of power, patients adopt a posture or gait that would expend less energy to compensate for the loss of power. But patients with functional neurological disorder do the exact opposite. So sometimes you see patients walking with knees bent, which would be challenging even with somebody who does not have any functional neurological deficits. And then we have this Hoover sign. So what is a Hoover sign? So this is an explanation of eliciting a Hoover sign for functional weakness of the right hip. So in diagram A, the examiner hand is placed under the heel of the right foot. Then the patient is instructed to push the right foot into the bed, which would normally press the hand of the examiner into the bed. In other words, extend his right hip. But patient is unable to do so due to functional weakness, i.e. voluntarily, patient is unable to extend the right hip. In diagram B, the examiner's hand still remains in place under the right foot, but the examiner instructs the patient to lift his left leg above the bed, i.e. flex the left leg, hip. So in functional weakness, due to body mechanics, the examiner will feel her hand being pushed into the bed by the right foot, indicating extension of the right hip. So what's happening is involuntarily, the patient is able to extend the right hip. So feed forward signals in the form of attention is being diverted away from the right hip to the left hip. In our patient who has functional orofacial movements, positive signs is lack of self-biting, lingual movements without mouth movement. So the tongue moves, but the mouth doesn't move, or the lips doesn't move. And then lip pulling, where there is tonic deviation of the lower lip with platysma muscle activation. In functional tremor, you get entrainment of tremor, which means that there is a change or elimination of the tremor of the affected limb as the patient perform a voluntary rhythmical movement by an unaffected limb. Whack-a-mole sign derives from an archaic game where a mole, when hit in its original hole, re-emerges elsewhere. So in functional neurological disorder, there is immediate appearance of an involuntary movement in one body part after movement suppression in another body part. In functional seizures, you have resistance to opening their eyes, and then this scenario of the patient asking what happened immediately after the so-called seizure stops. And this doesn't occur in organic seizure because of post-ictal drowsiness. So those that are interested to know more about the positive sign, this is a very comprehensive article published in the British Medical Journal in 2022, listing out all the positive signs for functional motor disorders and functional seizures. So we have the diagnosis. We must deliver the diagnosis, and delivering the diagnosis for functional neurological disorder is important because performing it badly potentially can perpetuate the functional neurological disorder. So it's important to not use pejorative terms, and sometimes showing and explaining how the diagnosis is made helps. Halpach et al. came up with a framework of how to deliver the diagnosis of functional neurological disorder, in this case, functional seizure, well. And the important ingredients are validating symptoms as genuine, naming the condition, providing a brief mechanistic explanation. So I usually use hardware versus software terminology, addressing effective and ineffective treatments, and fostering a hopeful sentiment of improvement. Patients' bad experience with previous doctors are many, and this is a list of what they say. They say that not getting a chance to describe all their symptoms, feeling that the symptoms were being dismissed or disbelieved, perception that the doctor was looking too hard for some kind of psychological problem, not being given a chance to explain their thoughts on the cause and treatment of symptoms, not being given a diagnosis, treatment, or anything that can read about afterwards, and not being given enough time. So the prognosis is poor in functional neurological disorder. Almost 40% of patients remain unchanged or worse after 7 years. But and among the subtypes, the remission for functional seizures is better than others. Treatment is limited. There is physiotherapy for functional motor disorders, and the central tenet for physiotherapy is performing exercises that would draw away the attention of the patients from the affected part of the body, i.e. distraction. And now there is a consensus recommendation on physiotherapy for functional motor disorders. A lot of effort is being made exploring other avenues, and one of them is transcranial magnetic stimulation, but results so far have been mixed. So take-home messages are that a functional neurological disorder is a condition in which primary pathophysiological process are alterations of functioning of brain networks. It is a diagnosis by virtue of positive signs, not diagnosis of exclusion. First consultation can be therapeutic, and success determines subsequent progress, and management is difficult. With that, I will say thank you.
Thank you very much, Prof. Azmin. Okay, we'll keep the questions at the end. I'll pass the mic to Prof. Nick first to deliver her talk. Then we'll have some Q&A if we have time.
Assalamualaikum warahmatullahi wabarakatuh. Can you hear me?
We can hear you, but we cannot see your...
Okay.
Yeah.
Okay, sorry. Okay, Assalamualaikum and good morning again. Thank you, Prof. Marhani. Thank you, Dr. Vien, and thank you, Prof. Shahrul, Azmin. For together, we are discussing this case that is rather complex and interesting for sure. But then, as Prof. Mani often said, that all our psychiatric cases, they are all interesting anyway. So I'm trying to discuss this case from a psychodynamic point of view, which can be difficult considering we don't have much time, but we try our best, but basically to understand what happened to this patient that forms this symptom manifestation that caused her to become muted person, almost anyway. So, yeah, just to recap, this is a lady who presented to us with a abnormal movement disorder. So fulfills the criteria of an altered voluntary motor function. And she has gone to so many different treatment settings, at least 5, I think, from what Dr. Vien has illustrated. And none of them actually gave any diagnosis until she was referred to the neuromedical team, who later on eventually referred to us. And the symptom is not better explained by medical or even mental disorder. And of course, it has caused significant distress to her. You saw it from a person who enjoyed sewing. She stopped that, and she has been filling her days with a lot of distress, especially on guard, thinking about a lot of things that are happening at the time. This functional neurological symptom disorder is a relatively new term. It was more perhaps commonly known as conversion disorder, a term coined by Freud, and Freud is not really wrong in naming this as conversion, which implies that it is a substitution of a somatic symptoms of a repressed idea. Basically, it implies it's psychological in nature, something that is that give rise to a conflict to a person, psychological equilibrium that is being converted or channeled towards or manifested as a somatic symptom. Functional is a new term that is thought to be more causative neutral, and hopefully it has less negative connotation, and it's thought to actually implies the functionality of it. There is, as Prof. Azmin already explained earlier, there is an abnormality in the neuropsychiatry, yeah? Okay. And there's a lot to digest as well. It is a functional problem, not basically a brain structural problem. Now, functional neurological disorder, or FND, is, as Prof. Azmin said, is often neglected, but it's also often misunderstood. I think many, even among the health professionals, there's a lot of perception that it is that patients are faking it, and therefore gives a lot of implications, negative implications to the patient as well as the patient's management as well. So as we outlined here, FND, or functional neurological disorder, belongs to this group of disorders that have manifested with medical or physical symptoms that are unclear with regard to the organic nature of it. So when it's actually more common than you think. I read somewhere that it's actually up to 30% actually patients presented to either medical clinics, neuro clinics, primary care that that did not have any explainable medical symptoms, and that has always tend to make us doctors uneasy, isn't it? Because well, we have to have a definitive diagnosis to be comfortable to be in that role of being a doctor. And of course, when we are not comfortable, that is also conveyed to our patients, that some, as Prof. Azmin already highlighted, some we can make them feel a bit slighted, dismissed even, or worse, ashamed with whatever that they are presented with. Now, just to look at this, how do you differentiate this group of somatic symptom-related disorders, which include functional neurological disorder, illness anxiety disorder, somatic symptom disorder, and also factitious disorder? Well, there is where it comes to symptom production, most of this disorder, patient did not intentionally produce it, they're not faking it, as compared to factitious disorder. All right, factitious disorder, yes, they did fake it, but we have to go a bit deeper. What was the motivation of having the symptom? In all these symptom, somatic symptom disorder, they are unconscious, and none of the gain that is conscious to them. Just want to illustrate a patient with presented with factitious disorder, for example, a child who presented with hemiparesis, and while it was intentionally produced, the unconscious motivation, perhaps from this illness, the patient may gain more attention for the parents, less quarreling, or avoiding the impending divorce, or so on. That is different from malingering. Yeah? Malingering is not a disorder. Malingering is a wrongdoing. It is wrong. For example, when you put your thermometer in a warm water to fake that you are having fever with definite conscious gain to avoid classes that is malingering. So just to clarify these the differences in terms of symptoms production, motivation, and conscious and unconscious gain that underlies this so-called unexplainable medical disorders. Yeah. Now, diagnosis gives us basically the what. What is it? Yeah, and in medicine, the diagnosis usually is etiological based. Yeah, it gives you a glimpse of the cause of the disorder. For example, myocardial infarction, it is ischemia of the myocardium, then it's easy. Now, psychiatric disorders follows the same medical based approach, but the difficulty that we often have is that, it's usually based on the symptomatology, right? And of course, the disruption in the function of a patient caused by this symptomatology. It usually have multifactorial cause, and therefore it is not enough for us to just give a diagnosis to the patient without understanding what actually underlies the symptomatology, the symptoms formation and symptoms manifestations of the disorder. So what we usually do, even for medical students, I think one of the first things that we teach you is how to formulate. Yeah. So this is the importance of formulation. While diagnosis gives you the what, formulation explains the why. Well, we can't explain to the patient that there is abnormal of your motor functioning or dysfunction, sensory processing, you know, the neurocircuitry. And we don't normally ask the patient why you are depressed, for example, because obviously that takes a lot for patient to understand. We are the one who gain or obtain this history and try in our best to formulate this to understand. Looking at the risk factors, it's not very difficult. They're different from medical disorders, other medical disorders, as we also look at these risk factors. Of course, we use a more sophisticated term, the vulnerability factors. You know, what makes the patient more vulnerable to develop the psychiatric disorder later on in their life. So this includes understanding the predisposing factors, which includes all factors. It's multifactorial, from biological factors, psychosocial, the social background of the patient, and in this case, spiritual factors as well, which contributed to the symptoms formation. And then the precipitating factors, the stressor that brought about these symptoms, that brought about or give rise to the intrapsychic conflict that sort of trigger the formation of the symptoms, and also trying to explain what are the factors that may maintain the illness if not addressed in the management. So it provides us a sense of understanding of the patient's present difficulties, but looking back as well at their early relationships and life events. So it is good as it anticipates and guides us in regard to the patient's management plans and also response to treatment as well. Now, so the main question to ask when you construct a case formulation is, why did this Mrs. R, who has been doing pretty well considering the life adversities that she had early on and some hiccups in her life, but nothing like as she presented, none as severe as she has presented the last 2 years, yeah, developed this specific psychological problem at this particular point in time at age 51 years old, yeah. So that's the question that we try to answer based on what is conscious to us anyway, right? Based on what we know and also what we try to understand. So let's try to formulate this case of a person who presented with this difficulty to become sort of a muted person, yeah. So now Mrs. R, she came from a sociocultural background that actually may not allow her so much in terms of direct expression of emotions. I think it's quite well known in certain social background, well, maybe due to the gender role, religious beliefs or other factors, that direct expression of emotion is not so encouraged. And that has, I think, one of the risk factors in conversion disorder that is quite clearly established as well. Another factor is that there are conversion symptoms usually occur in those in lower socioeconomic groups and family backgrounds which have lack of knowledge and awareness about medical diseases. And there are studies that showed that exposure to certain medical symptoms that were unexplained, the patients tend to adopt a similar symptom from members of their family that adopted this in the past, and when they believe that it's part of their family history, as illustrated. The mother also had at some point developed some oral problems. Yeah, I'm not sure whether we are too speculative at this point, but well, trying to link with the evidence base as well. So Mrs. R also, as we learned that she was exposed to multiple childhood adversities. The father was religious. That was not an adversity, having a religious father, but it did instill, in the theories of personality development, it did instill a rather strict and maybe quite harsh superego to a person, to a child who's developing a personality. One of the factors. So, well, more importantly, he was hot-tempered. While there was no definite physical abuse, there were incidents where he just threw meals whenever he didn't like it towards the wife. Shouting is a norm there. And at the same time, Mrs. X recalled that most of the time he wouldn't even dare to ask the father for any pocket money. They had to work at the coffee. It's not the coffee shop, sorry. It's the coffee farm where the father was also working while schooling. So there's definite adversities there. And we know, not even if you think psychodynamic theory is, well, pretty irrelevant, but it is relevant, as you can see here. Childhood adversity has also established its root when it comes to the development of psychiatric disorders. Yeah, okay. So I already mentioned about the strict superego that patient develop with this having a very strict father. And also with that in mind, patient may have this notion that losing control or even feeling anger is a bad thing. It's not something that you do if you're a good person, right? And of course, the patient also has some, I know in the family history, there was no definite psychiatric family history, but we know the son has schizophrenia, so we're not too sure, because back in those days, perhaps not too sure about how aware patient or the family is about the psychiatric disorders itself, right? Okay, with that kind of parenting also, the chaos in the family may also lead to a patient developing rather insecure, anxious, and fearful attachment style. And you can see that even as a child, when she was primary school, because I saw the patient said that when she was in primary school, she would make sure that she would go to school very, very early. If not, she felt very, very anxious. She's one of the few people who actually who did the homework very religiously and so on. And we can see also later on, she's very obsessional with her. The traits that she carried is being perfectionist, which is very particular, even in her relationship with her children later on. She's very particular about the children's academic, worry about their whereabouts and so on. Mrs. R continued to suffer losses, some adversities in her life. Her father passed away when she was 16. It was quite young, and whereby the mother had to be the breadwinner. She had to care for the younger siblings. There were 10 of them. She's seventh. She's number 7, while at the same time studying. And she did study. She did very well. She performed very well and was actually offered for Form 6, but she declined due to her own obsessionality, wanting to perform the best and worrying about not being able to perform. Again, when she's 19, her mother developed the oral condition, and she was tasked with as the main caregiver. So mother passed away when she was 20, and she most of the time she either she coped in a religious manner. Yeah? And that is a very important and significant aspect of her life. You can see that she's rather at peace when she married someone who's very supportive. The husband has always been described as supportive, caring, and loving. And when she chose herself to become a religious teacher, that is very much agreeable with her personality as well. Okay, so we sense that the loss of mother is something significant, but all the while she managed to cope with the difficulties with by utilizing sublimation. She worked very hard, she got the results, and also a lot of religious coping as illustrated earlier. But somatization is something that we noted on and again she utilized as well. Not just this presentation, but this is the most severe, I suppose. Previously, she did have similar jaw dystonia and a few other somatic complaints, as Dr. Vien outlined earlier. So, and it does in coincidence with the life stressors. Yeah, at one point she was almost worried. She almost lost her husband, who was about to be deported, but that the symptom diminished when that was sorted out. So the recent stressor, perhaps the most conflicting in her life, where 2 of her 3 children, she's very proud of her children. She really, and they are very successful. The first one is actually doing masters, I can't remember exactly, but she was the one who suddenly fell ill and eventually diagnosed with extrapulmonary TB. But that is like orang kata sudah jatuh ditimpa tangga. After that, the son was actually diagnosed with severe form of schizophrenia as well. So this perhaps become very tested her religious belief, as she's tested with threatened loss of her children, which brought about this perhaps a lot of anger, and that with anger comes guilt towards God that she could brought us that. If you notice, the first symptom manifestation happened when she was reciting prayers, and this conflict manifested in with such difficulty to speak. So perhaps this anger needs to remain unconscious. It is too anxiety provoking for her and unacceptable for her, considering the background. In her own words, she said, "I would rather be mute than experiencing this pain." Now, so I suppose that putting this together help us a bit to understand the symptom manifestation in this patient. So formulation doesn't have to be psychodynamic all the time, but what makes a formulation psychodynamic? That is looking at the unconscious drive of a person that lead to symptoms formation. Where we combine the cohesive hypothesis. This includes some psychoanalytic theories, plus other theories, attachment theories, psychosocial developmental theories, and incorporate with patients' own interpersonal and unconscious processes, which then make sense to how it influenced how one's think, feel, and also how they behave. So it does focus on conflicts that may be threatening to a person, where, for example, in this patient, having this feeling anger towards why this family maybe is letting me down, God is letting me down, despite my being such an obedient person, doing everything that is what God asked me to do, and I'm tested with this. And the strict super ego saying that, yes, you have to continue, you have to be sabar, you have to be tabah, and all that, the things that people say when a person is tested. So it does give rise to conflict. Another thing what psychodynamic does is explains how and why the patient utilizes this defense to resolve this conflict. No doubt it is in a maladaptive manner, cause her more distress and so on. Now, this so-called maladaptive resolution of conflicts, which here it is in the form of somatization. If so, for example, in this case, that she presented with this movement disorder, not being able to recite prayers, not having talking to, she didn't. If you notice in one of the first videos, she said she was okay talking to me in the clinic. That is she was doing perfectly okay, actually, we could understand. But the moment she goes back to not even home, the car to bring her home, she felt the difficulty is worsening actually. So it also attempt to identify the area of maximum psychological pain, this feeling of being betrayed, being let down by family, and also God, and how the patient defends against it. So this is just to go through, do we have time to go through a bit of psychodynamic theory that we incorporated to understand? For the basic ones, that most of what is conscious to us is just at the tip of iceberg, but many of our drive, our impulses lays beyond what is conscious to us, okay? And particularly things that are anxiety provoking and not really acceptable to our to being our understanding of being a good person. So that usually lies within deep and not really conscious to us. While this topographic theory of mind explains more of how information is being stored, it doesn't really explain how a person develop symptoms. So Freud extended the theory into structural model, whereby the mental processes consist of these three dimensions, which is our id, which is the most basic, where we are born with our instinct, desires, and later on ego develops, whereby ego comes with logic and reality, considering what other ones as well, not just ourselves. And the superego later on maybe at age 5, the moral guidance that we have as we being brought up, being parented, and so on. So the id and superego seems to be opposing each other. The id is what I want, the superego said that you shouldn't be doing this, and the ego is trying to reconcile this so that you are in this psychological equilibrium. It's like your physiological homeostasis. You need to be everything in balance. So similarly, our mental processes need to be in this psychological equilibrium where balance is strife and not causing us symptoms. But if the anger, the aggression arises and cannot be reconciled with superego, and whatever that works before, the coping that you use, for example, working hard to reduce this anger, it doesn't work anymore. So that is when supervision, the symptoms arises. So just a glimpse of what we are, the defense mechanism. This is something that I think even medical students need to understand a bit. Yeah, I think they were questions EMI, I think past questions that asked from this topic. So defense mechanisms are attempts at adaptation. Most of it will be adaptive, that allows us to function normally, to be at peace with whatever we are doing. But there are times, sometimes whatever the adaptive defense mechanism that we utilize are suboptimal, and then it can be maladaptive. So just to give you a bit of a glimpse of an array of defense mechanisms, there's so many, but some of it are more maladaptive, immature, and that doesn't help with our functioning if repeatedly utilized, and some that are rather highly adaptive. For example, humor, being able to laugh at yourself is good, right? I mean, just now, I think the last slide from Prof. Azmin saying that we are all morons. Yeah, I don't know. I saw it as black and orange or something like that, and that was funny too. Yeah, because at the end of the day, when we are just discussing something that is complex, at the end of the day, we have to come to the admission that, well, what do we know about it at the end? Yeah, what do we understand it? Okay, so that is just an example. In view of the time, I wouldn't go through each of these defense mechanism. Repression is usually the main, the most common defense mechanism that you utilize without even realizing it, blocking the ideas that are not comfortable to you. Yeah, so we found ourselves forgetting things that you don't really like to talk about, for example. And I think that is also common. Somatization is what the patient utilize, where you express a difficulty in with physical symptoms. Tiba-tiba sakit gigi, sakit kaki ke whatever kan, that cause you not being able to do what you don't really like to do, for example. And denial can be adaptive, can be maladaptive. But I won't just go through because in view of time. So all these need to be understand now. So how does psychodynamic understanding facilitate the management of this case? Well, as you can see, it is very, very frustrating to go around to all sorts of, patient has gone to quite a number of hospitals. I think this is her third hospital, if I'm not mistaken, and being told the same thing. It was, nothing is wrong with you. It's all in your head. But, well, it is in your head, but there is some thing that is going on in the head, right? Doesn't just because we don't understand it doesn't mean that we, there is nothing in that. There is nothing wrong with you. So it helps you to empathize, engage, and build that therapeutic alliance. The patient was able to be engaged. There was a lot of resistance actually, but the daughter is the main person that is easy to be, that help us in engaging the patient. So as you can see, she was offered physiotherapy and she did, but she didn't like it either. Pharmacotherapy did improve some of the symptoms, but again, can see that caused a lot more difficulties as she refused to take. But practical help, at the end of the day, I think this stressor, the main thing that is causing her conflict, is the one that is actually maintain her illness, that if failing to resolve that also would maintain the illness. So we did liaise with Hospital Putrajaya, and patient, if I'm not mistaken, was the son was started on clozapine for the treatment resistant and became more manageable. And at the same time, stress management, in terms of the distraction technique that Prof. Azmin saying just now, and we asked in detail what patient like to do, and I think apparently one of the things that she enjoyed is gardening, and that helped also to reduce and make her more tired and sleeps better. Previously, she hardly slept, and she was actually on guard all the time, was so worried about the son. Okay. And psychotherapy, while we understand psychodynamic formulation in this case, we don't, it's not indicated in this patient as we understand it, this, one of the conflict is this anger towards God, perhaps, and one of the coping is actually through God. So that conflict is very hard to resolve. If it's uncovered, may cause further conflict to her, right? So, and of course, again, it's about her being, whether she is receptive enough, psychological minded, and so on. So the aim, the the focus is more on understanding and trying to reduce the stress that she is experiencing, and that increase the understanding of what she is dealing with. Actually, that is a son who is having schizophrenia that can be treated, and hopefully that gives a bit better hope for the patient. I think that's all from me. Thank you.
Okay, thank you very much. So it's past 9 now, so we cannot afford to have any Q&A. I would like to take the opportunity to thank all the speakers, and maybe to do a little recap. So thank you, Dr. Vien, for sharing the case. It's not often actually we get a functional movement disorder or functional neurological disorder. So hopefully everybody learns from this case. And Prof. Azmin, thank you for highlighting the physiological aspect or neurological aspect of a functional disorder. It's not so the message that the audience should get is this is not a disorder that you do by exclusion. By excluding the organic causes, you get the diagnosis. You have highlighted positive signs also that you should look for to support your diagnosis. And I really like your framework of delivering the diagnosis to the patient. I think that would be an important first step, before you actually embark on any psychotherapy, because the symptoms are very physical, so the patients may not be ready for psychological intervention, but the message from the framework you shared just now is that to acknowledge the symptoms as genuine, and also to give the explanation, the physiological explanation, what happens in the brain that actually produce the symptoms. I think that would be an important first step to help the patient. Thank you, Prof. Azmin, for very good messages. And Prof. Nick for highlighting the psychodynamic aspect in understanding a condition like this. Definitely psychodynamic aspect and formulation is relevant in most cases, and particularly on this one. There have been childhood adversities and past experiences do actually change the way people view the world, view themselves, and perceive the bodily sensations in their body and so on. And not only that, actually there have been so many research showing that the experiences in the past, especially during childhood, not only change people in a psychological way, but with the involvement of biological changes in the brain as well. So that's what Prof. Azmin was trying to highlight on the physiological aspect, as well as both actually goes hand in hand. So body and mind is actually one. So with this discussion, including the psychological aspect as well as the neurological aspect, makes me makes me feel like a family with with neurological. Right. So I think that would be the best way to actually approach treatment for our patients. All right, so thank you very much to all the speakers, and thanks everybody for attending this CPC. So I would like to wish a very good day to everyone, and the students can stay back to answer quizzes. So I'll pass over the session to the organizer. Thank you, everybody.
Thank you, Prof. Marhani. Thank you, everyone. Thank you, Azmin and Vien.
Thank you. Thank you for inviting.